Hello and welcome to HFMAtalk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In this episode, I'm joined by Richard Mellor, Director of Finance at Locala, a community interest company. Many areas of the country have some NHS community services provided by community interest companies as a consequence of a change in NHS policy around 2008. But this is an area which is often overlooked. Richard joins us to explain a bit more about what being a community interest company means, how they work with the NHS and the freedom it gives them to be more innovative. Hi Richard, thank you so much for joining us today to have a chat on HFMAtalk. I wonder if you could start off just by introducing yourself and telling us a bit about the services that your organisation provides and the population that you serve.
Yes, thanks Sarah. My name is Richard Mellor. I'm Director of Finance for Locala Community Partnerships. The organisation is a community interest company and we're based in Kirklees, which is just south of Leeds. So the organisation was set up in 2011. It came out of the Transforming Community Services changes within the NHS and was the community services element of Kirklees PCT. So it was set up as a separate organisation. It's a limited company, which is subject to the normal rules for a limited company, but also falls within the community interest company regulations. So we're established as a social enterprise for the benefit of the populations that we serve and providing NHS and public health services. The services that we provide are very similar to those of NHS community trusts. We provide district nursing, community therapies, health visiting, sexual health services, some GP services, walk-in services for minor injury, MSK, immunisations and specialist dental services. We started off in Kirklees and over time we've spread slightly, and so we now also run some services in Bradford and Calderdale, but we're still a relatively small organisation in terms of NHS trusts.
So you've obviously been in the NHS for quite a number of years. So how is being a community interest company different to working within the NHS?
So in many ways, I'd say we operate in the same way as an NHS provider organisation. We're providing the same sorts of services. We have contracts with the CCGs, with NHS England and local authorities for public health services and NHS Commission services. We work to the same efficiency requirements that are within those contracts, and the services that we provide are regulated the same way in terms of the CQC. So that all feels very similar. And to me, having worked in the NHS and then worked in Locala, it feels very much the same in that respect. I think the differences are around the fact that we are incorporated as a limited company, and to that extent we stand alone. So we aren't within the direct remit of NHS England or NHS Improvement, although we are licensed to operate by NHS Improvement. And so our principal arrangement and links in is via our commissioners, the people who hold the contracts that we are providing, rather than with further control or oversight by NHS Improvement. Consequently, we don't have a number of the reporting requirements that we would have as an NHS organisation, and the constraints on us are around managing our finances because we don't have a fallback. If we're not able to manage within the resources we have, we can't continue to exist as an organisation. But with the flexibilities about how we perform the services and how we might do things over and around that, particularly thinking about our social enterprise role. So provided we are sustainable, we've got those options to do things differently or to do different things.
So you mentioned financial reporting there. So do you have to provide anything to the NHS that a provider normally would along the lines of costing returns or monthly financial information?
So no, we don't report in either to get our plans approved by the NHS or for our monthly reporting figures. We do produce those reports, so we produce an annual plan with budgets, with efficiency requirements, which is very similar to those of an NHS organisation. We determine ourselves the surplus that we are aiming to achieve, because whilst ultimately, if we make any money, that then goes back into either the services that we provide or into supporting or developing the community, we also need to have a financial position that's sustainable. So we're operating in the same way of being a sustainable organisation and having financial plans, and we then report upon them monthly, but that's reported to our board and not through to the NHS.
Thinking about integrated care systems and some of the reporting and the planning requirements around that, presumably as the local community provider, you'll be feeding into all of that process and having to provide some of this data and information to the ICS that perhaps you don't regularly supply now.
So the ICS, I think we are lucky in terms of the area that we report within. The ICS we're part of is the West Yorkshire and Harrogate ICS, and we as Locala, as a community provider in that patch, are included within the ICS arrangements. When there are things going on which are the whole ICS and including the local authorities, ourselves and the NHS, then we are involved, and if figures were required, if work was required, or there are things we're looking to achieve together, then we will report into those. But when it is just the NHS reporting, then we aren't within the control total regime. Any contracts we have are through generally the commissioner. So for us, our lead commissioner, which is Kirklees CCG. So we report into the ICS for information that's appropriate and that we're asked for, but where it is the management of the overall NHS budgets and control totals, we are not included within those numbers.
So community services as a sector, NHS community services, has historically had quite a lot of problems, challenges around understanding activity, data, costs for activity, etc. But presumably as a limited company, you have to have that better handle on your cost base. So how do you go about understanding what you're doing as an organisation and what you're delivering?
Yeah, so the way that the organisation has chosen to set up its budgeting system is we have cost centres which are around departments or different services in the same way as you might expect. But what we have then done is taken the contracts that we hold and shown the income in detail against the individual frontline services. The support services then become an overhead against those services. So we're producing budget statements which represent the contribution, effectively the profitability before support services for each of the frontline services, and then the support services operating to a budget which is again supported by those contributions. So it's not patient level costing or reference costs, and currently we don't submit reference costs or produce patient level costs. I think that is something where we could do with improving what we do and having a better understanding of the costs that we have. But the focus that we've had previously has been around the contracts and whether or not they are sustainable and affordable so that they work for us. Because coming back to one of the previous questions where we've talked about the planning and the budget setting, the principal element where we probably spend more time than I'm used to within the NHS organisations, where a lot of the contracts roll over year on year, is looking at when does our contract run to, what are the extension periods, what do we need to do to ensure that we're delivering a quality service, because if we're not delivering a quality service, it will make it more difficult for those contracts to be extended or for us to win when they are tendered. But not only that, we need to be fairly good at putting a tender in, because it's that none of the business that we have is certain beyond the length of the current contract period. So knowing whether or not a service works for us financially and we're able to deliver the KPIs and the contract requirements is important. And so a focus around the services is, are we able to deliver them, and can we deliver what's required, and are we delivering to the appropriate quality? And that's probably more of a focus for us internally than the detail of cost per item. But I think, as I said, that there is work that we need to do, because we need to have a better understanding of the detail costs, which might be akin to a Plix type solution, because we know it at contract, but do we understand what the individual drivers are?
So does your contract, or is your contract quite detailed then in terms of the funding that you get to deliver particular services, or is it similar to a block contract and some of the detail is less clear than it could be?
It's a bit of both, depending upon which contracts it is. The largest contract that we have is a block contract for community services, and it has a mix in it of some areas which are quite detailed and others where it's really a continuation of what was happening previously, and there isn't a lot of detail either about what the service then involves or how it would be reported against. And so those are things that we're, I think, very clear about the things that are being measured. Where it's less clear, that has involved discussions with commissioners about just exactly what is involved, and how that either should be measured, if it should be measured, and what should be delivered. So a number of the contracts will iterate as we go along, and particularly if we get to an extension period where there's the opportunity to pick up things that were not clear beforehand.
So I was working in a PCT when Transforming Community Services came about, and I separated from it with the community services into a new NHS organisation. But we looked at community interest companies as an option at that point. And one of the things that was spoken about was the opportunity to offer services to other organisations, not necessarily within the NHS. So do you contract outside of the NHS? I assume you probably do with the local council, local authority.
Yes. So I think when I'm talking about the NHS and or the community and public health services, I'm including the local authority contracts. So we undertake early years contracts, we undertake contracts within schools, and for sexual health services, which are in some cases directly with the schools, but in the large majority of them are through the local authorities. I think there is the opportunity for community interest companies to both diversify the services that they provide, and also to do things differently or to do different things within the remit of, first off, we need to be sustainable as an organisation. Secondly, that any surpluses that we might make, and that includes returns upon anything that we are doing that might be different, is reinvested back either into the organisation itself or for the benefit of the local population. For Locala, I think we have tried a few different things, but we haven't probably made as much of the opportunities from being a social enterprise as possibly some other social enterprises have. We have seen social enterprises, including those that came out from the NHS under Transforming Community Services, who have got supportive businesses or have expanded how they deliver their services. It's something that we are looking at now, because I think there is the opportunity for us to do that. Whereas how we have supported and given into the local community over the past few years has actually been through supporting voluntary or other community organisations, largely through the provision of grant funding or supportive donations to them. rather than through us doing anything significantly differently.
And do you think that as an organisation you have a different relationship with your population and quite possibly your staff as well because you're a social enterprise?
So I think with the staff who we have within the organisation, it does feel that there is more engagement, that we are possibly a bit more flexible, but that every colleague who works for us is a member of the organisation and a shareholder. We have quite good engagement through those members into what we call the Members' Council, and the Members' Council is for both colleagues and also for members within the wider community. And they support a non-executive member of our board, so we get a feed through from the members directly to board level and back. And that level of communication and involvement does seem to be higher for us than I've seen in some other organisations that I've worked in. It feels like people are more engaged rather than feeling that they're working at the organisation. They're working with us more, and we involve them in some more of the decision making. The community members is interesting because we do have a number of community members, but compared to the size of the population that we work with, it's still a relatively small number. So there is engagement, and the people who are engaged with us are very committed to that and give a lot to us, but it's still only a fraction of the population. And if you look at it against Foundation Trust, then the impact from the local population is probably akin to the governors that are involved. I think the main difference where we do get more involvement on an ongoing basis is from our colleagues.
Yeah. And just going back to something we spoke about earlier, to some extent you've obviously got the benefit of not having to report directly into the NHS through NHS England and Improvement and all the various reports. But thinking about that on the flip side, NHS bodies have quite a large support network around them. In terms of some of the guidance that exists and the networks that exist around NHS bodies, is there a similar type of network and support available for community interest companies who are working in the way that you are?
So there is, as you say, a lot of guidance and support for NHS organisations, and from the finance perspective, a lot of support in terms of the reporting and the statutory requirements. And we do have to support that ourselves, make certain that we get the appropriate advice or training. But in a similar way, the NHS organisations work with their auditors and have support from auditors to get the information. Then we are able to get that from our auditors. On a wider basis, I've contact with directors of finance of some of the other community interest companies. So we are able to speak to each other, ask questions if we have them. And we're a part of Social Enterprise UK, which both gives us a group to pull together and to ask questions and to be able to get contacts across a wider footprint, and also provides support and lobbying for us if there are issues that we have that when we raise them, we realise it isn't just us that's in that position, there is a wider group, and they're able to then provide a central support, lobbying if required, to be able to raise that issue in the general awareness or with an appropriate party. So the support is available, but it's not to the same extent. There are a number of other areas that we need to make certain that we have taken our own advice and that we are covered for.
So obviously you've just talked about where you don't have quite so much support around some of the areas that you might like. Are there any other disadvantages to being a community interest company? Is there anything that you think could be different? I know within the HFMA we don't always consider that part of NHS provision when we're putting together publications, for example.
So I think the disadvantages come from the fact that we're sitting on the edge. Certainly from Locala's perspective, we feel very much a part of the providers of NHS services, but we are not an NHS body. And that does mean that there are some things where we might like to be included, where either we aren't or we have to ask or struggle to get included. And some things where actually we can do things differently, and maybe we haven't taken the opportunity to do so, but other organisations have. So we get that the benefit against the fact of not being included for some things. For HFMA, when I was in the NHS, I wouldn't have actually thought about community interest companies. So I think the lack of consideration of them is probably the basis around we are not a large cohort, and probably where we are members individually of HFMA, we maybe don't have a voice or don't raise that voice. And so consequently, we have the potential to be forgotten. So I'm grateful for the opportunity to say we are here, we are providing NHS services, and could you please remember us? It might only be a small part or a consideration for some of the work that HFMA is doing, but it would be helpful to be included. Because I think what COVID has highlighted is with ourselves, and I believe for some other community interest companies who provide NHS services, we are on the edge of that NHS bubble and response. And our involvement has sometimes been difficult. So we're a responder under our contract, and in respect of responding to COVID, we have taken the necessary steps as requested, turning down the services where we can, putting resources into support for the response to COVID. But what we do find is that not being an NHS organisation can mean that we are sometimes missed out. And what possibly is not known within the wider NHS sphere is that we're not necessarily included and continue not to be included, despite the fact that all of the rules and expectations would say that we should be. And that includes things like being missed off some of the information that comes out because it goes to the NHS lists, but doesn't include non-NHS providers. It can include things like being on the tests list, and we don't get included in the same way as NHS organisations. So the rule is, or the instruction is, all NHS staff need to be tested, and we don't class as NHS staff for that, or at least have to fight to be included. Whilst HFMA can't address those wider things, and we need to keep lobbying to make certain that we are included within the groups appropriately for those sorts of things, it does tie back to us being seen as a part of the NHS provision of services, and where it's appropriate for HFMA to represent us when they're looking at how healthcare finance staff are represented, that they do so, and we go through the other routes to be included as NHS organisations, so that what the term NHS workers includes our staff and people remember us.
And were you included in the sort of COVID top-ups at the early stages when costs are being reimbursed due to COVID? Did that cover you as well?
So it did, but indirectly. So we're not an NHS organisation, so we weren't covered in the individual organisation top-ups. We have been lucky in the support that we've had from Kirklees CCG, who are our main commissioner. And so very early in the process, when the COVID funding was being identified and the rules being put in place for that, they spoke with us, and we have been making claims throughout the year against the COVID funds where we've incurred additional costs, making claims to the CCG for inclusion within their submission. So that has been very helpful, and they've been very supportive to us over the period.
One of the things that's been raised from some of our community services members is that the pandemic has really raised their profile, and their involvement in some areas where they weren't previously being heard has improved. What's changed for your organisation as a consequence of the pandemic?
So I think that we have had the same experience, that community services, as part of the response right from the start, have tried to do our part, and Locala has done the same as other community organisations in putting resources into those parts of the service that can avoid hospital admissions, can help take people out of hospital, and where people were discharged from hospital in the first wave, to try and support them outside of hospital, whereas previously we wouldn't have taken that cohort of patients on. We've also added a number of services in, either enhancing services that were already there but needed to be larger or to be able to support more patients. And we've also started new services that we didn't have in order to try and cover the things that now can't be done either in hospital or that now are taking place virtually or at home because of COVID. So I would say we have been able to step up and support. In the first wave, that did mean a number of services then being paused or significantly stepped back. And I think that's common across the community organisations. But what COVID has shown and allowed is that the underlying narrative that has been there about improving and increasing community services, we've suddenly had to do and to put into place. So our profile's been raised, we've been able to show that we can do some of these things. The question going forward is how many of them can we retain? And where we have changed our practices, particularly using technology or taking people onto caseload who previously we would not have taken because they have too many issues, too many comorbidities, they are too unwell. How do we maintain the positive parts of that, the parts that really worked well, or the things which really support the system, and not return to doing things the way that we used to?
Absolutely, and that, as you say, that is a common message across many organisations. So you've mentioned in one of your previous answers that being a community interest company allows you to reinvest in your services if you have the sufficient funds to do so. So have you done that, and what benefit have you seen from it?
So probably a bit different from investing directly into the services, but in terms of giving benefits to the community, we do have opportunities as a social enterprise to do so, provided that we have the funds. And recently, particularly from COVID, where we've seen impacts across social isolation and problems with social isolation, we've invested in providing mobile devices and, where people didn't have Wi-Fi, the mobile data, so that a number of people who are identified as having social isolation problems and needing support can be provided with the tools that they don't have themselves in order to be able to maintain contact, and the infrastructure put in place to support that contact and to make certain they're kept in touch with. And something else that we've done, which we're just starting off, is around providing internships. So recognising that there will be both young people who are struggling to either get experience or to get a job coming out of school, particularly with the issues at the minute, to give them the opportunity to come and get experience, to provide some benefit to us by being a pair of hands, but to give them an opportunity to learn and to earn for the period that they're with us, to set them up either possibly to then want to come in and work for us and to get the training that might move them into the care sector, or to give them the opportunities across the wider workplace so that we increase the opportunities that they have. So those are things that we couldn't do directly as an NHS organisation. It's about supporting people in our locality and trying to give them opportunities.
So thank you for your time. I have one final question to ask you, and that's about what's the key piece of learning you'll take from the experiences you've had over the last 12 months?
Yes, that's interesting, because I think the key thing is in looking at how all of our colleagues in our organisation and across the wider piece have responded, is there isn't anything that we can't cope with and do given an appropriate impetus. Often what we haven't managed to do is take those steps either quickly enough or be brave enough to make some of the changes that will really make a difference in how we deliver care. It feels like we've made a step difference in how we provide some of the care pathways, and that we don't want to lose that change, the positive change that we've seen, but recognising as well we need to bring back online services that we'd cut back because we've impacted some patients because they're on waiting lists, they've had delays in treatment. So how do we keep the good and then get back on top of those patients who've been delayed whilst the response to COVID was happening?
Thank you so much for your time today, Richard. It's been really interesting, and I've certainly learned a lot about community interest companies that I really had no idea of previously. So it's been really valuable. So thank you very much.
Okay, thank you.
Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.